the queue. So with that, let me get into introducing our guest faculty speaker today. And I've known Dr. Tanaka. We've worked on anthrombin 3 over the years, so I've known him for quite a few years. So it is a pleasure. Dr. Tanaka did receive his medical degree from Keio University in Tokyo, which is located in Japan. He's completed a residency in his anesthesia residency at UPMC in Pittsburgh, and then a fellowship at Emory University as well. He's got a Master's of Science in Clinical Research from the graduate program at Emory, and he's also a diplomat in the American Board. Dr. Tanaka is the professor and chair of the Department of Anesthesiology at the University of Oklahoma Health Science Center. But he's been involved in a tremendous amount of research throughout his career. You can't search hemostatic activation or coagulation disruptions without pulling his name in multiple papers. He serves on the editorial board of a number of journals, including the Red Journal, the British Journal of Anesthesia, and both Anesthesia and Analgesia, as well as many others. And so today, Dr. Tanaka is going to be presenting on unique aspects of managing Jehovah Witness patients. So with that, I welcome Dr. Tanaka to take the screen and begin his presentation.
Thank you, Al and Jeff, for the invitation. It's a great pleasure to be here. And can you see my screen okay?
Yes.
Yeah. The presentation mode now?
Yes,
okay.
Sir.
All right, so I'll be speaking about Jehovah's Witness, those who are undergoing cardiac surgery today. And I have some COI mostly related to research. One is for a freeze-dried platelet study by Cellfire and US Army, and the other one is a PCC study by Octapharma. And none of the companies had any input in today's talk. All right, so key points today are threefold. One is to think about role of patient blood management, and then go over some of the key blood conservation strategies. And lastly, discuss how patient blood management culture can support bloodless surgery, especially in Jehovah's Witness patient. So I saw this very nice picture in Dr. Bracey's review in Transfusion recently, and this really depicts what we used to be. And here you have a very large cardiopulmonary bypass machine. I think this is an oxygenator. Maybe Al has seen or worked on this type of device some time ago. But look at the amount of blood they prepare for this surgery, probably 10, 15 units of whole blood. So we have come a long way from this. And if you also notice that these perfusenists and nurses, they are not watching iPhones and texting anybody. So back in the day, it was totally different, very much focused. So I think long time ago, we were using blood all the time, but I think this pioneering work by Dr. Cooley, published in 1977, it really brought a paradigm shift in cardiac surgery. He operated more than 500 Jehovah's Witness patients without blood transfusion, and you see that age range was quite varied. And if you look at the 30-day mortality, out of 362 cases, mortality was 10.7%. So this is a damn good result back in the day. And only patient who died from anemia, well, basically 12 patients, and 3 had a hemorrhagic death. So this can happen any type of case. So I do think he really showed if you make effort in blood conservation, you can achieve this type of practice. So what is patient blood management? Of course, it is a patient-centered approach. We focus on anemia management before surgery and optimizing intra-blood conservation and also coagulation. So you have 3 tiers after patient decides to have bloodless surgery. But we have to also think about what is the impact of just giving a transfusion to anemic patient on clinical outcomes. And also, if you look at the national blood supply, we have a huge problem of aging of donor population. And recently we have seen the supply-demand issue becomes a really serious problem when the pandemic hits, the country or even the worldwide. So why do we have to think about blood alternatives? Of course, first that comes to my mind is blood component shortage, and then more recently, epidemic or endemic. So think about the aging donor population. So back in 2011, you have a donor age ranging from 45 to about 64, and that is shifting toward much older populations in 2019. And this trend is likely to continue. So some of the donors may be declined to donate the blood because of the anemia, serendipitously found anemia when they come to the donation center. So I do expect more and more issues in the supply chain. And another good example is this. In the beginning of pandemic, we of course had an excess blood supply because we stopped surgery. But as soon as the surgery resumed, you can see serious shortage, that is really prolonged over time, almost a year. So, we have to expect some blood shortage when something bad happens, say mosquitoes, some new virus emerging in some countries can affect the blood supply in the United States. So we have to keep that in mind. So actual blood shortage, we commonly see that the red blood cell shortage and platelet shortage, especially in cardiac surgery, oftentimes we have to cancel or postpone the case when we have severe platelet shortage. But if you look at the supply issues during the COVID, sometimes you see supply shortage for FFP, fresh frozen plasma, or cryoprecipitate as well. Probably toward the end of this pandemic era, cryo shortage was caused by resuming surgery. So resurgence of surgery actually required more cryo transfusion in our surgical population. So that's my guess. But just expect, from time to time, we'll see this type of pattern in the future. So other issues we have to think about, allergy or alloantibody formations. We have increasing number of allergies in children and young adults. So this might also affect transfusion-related allergic or anaphylactic reactions. And some of the patients are very, elderly and they do not tolerate high volume transfusion. And of course, some of the therapies like platelet transfusion may not work in some patient, and we have to repeatedly administer these products in the same patient. And lastly, and most importantly, I think Jehovah's Witness is our special population that we have to think about blood alternatives. So I do not have to go through the details of what they expect and why they don't, because most of you have already seen this type of table. But I do think that some of the products that became available recently, fibrinogen concentrate and prothrombin complex concentrate, although they are off-label indication in this population, they definitely help us manage in preventing severe bleeding issues after cardiopulmonary bypass surgery. So when you think about bloodless surgery, we have to think about how low can we go. So in terms of hemoglobin, based on the data by Dr. Shanda and Dr. Carson from Englewood and Rutgers in New Jersey, I think hemoglobin 5 is definitely the critical area, and below that range, I think you have much higher mortality rate. And you can see that below that 5 range, you can see a gradual increase in the mortality rate. And you can also see this in the lowest hemoglobin level and then predicted probability based on this type of data. So below that 5 range, this curve actually becomes much more acute and drops down significantly, reducing the probability of survival. So preventing anemia, severe anemia, is a key to bloodless surgery. So what data do we have? So they are mostly empirical data available because it's really difficult to conduct any type of prospective study in this population. So one study by Helwani this year's publication, they looked at the severe anemia occurrence in Jehovah's Witness patient, less than 7 grams per deciliter, and they looked at the mortality 30-day, 90-day, and 1 year. So what did they look at? So the patients with severe anemia, only 9 patients versus non-severe anemia, they were 39 patients. BMI, age, most of the numbers, heart hypertension, heart failure, and the type of surgery, they were relatively similar, but there was a trend for more urgent procedures and then higher re-exploration rate in severe anemic patient. I think this is somewhat expected. Now, if you look at the survival, you can see some of the patient died really early, and then some patient died probably around 45 days and later. So overall survival rate was about 45% in their population. So how did they die? So it's only 4 out of 9 patients. And if you look at the nadir hemoglobin level, pretty low, 20 or less. And some of them were way below 5. And they actually had some end organ issues such as stroke, multiple organ failure, and sepsis and cardiogenic shocks. So it's really hard to pinpoint that anemia per se was a cause of death, but it could definitely be a contributor to end organ function or dysfunction. So to summarize this study, I think this is definitely an underpowered study, but it really highlights the potential risk of death when it comes to severe anemia. So it corroborates previous data. So let's look at another data. This is the newer data also published in the Red Journal, Journal of Cardiovascular Anesthesia. So this is a 21-year experience in Netherlands, and they actually had a highly selected population, and they had a program for pre-op anemia management using EPO and iron and multivitamins. And they specifically targeted hemoglobin 13.7 for men and 12 for women. So I actually disagree with this target because I do think that female patients tend to have more transfusion because of the body surface area. So probably we should target, at least the same hemoglobin level before surgery. Well, intra-op, they kept the hematocrit above 22. And early on, they were using A-protein, but of course, because A-protein was taken off the market, they switched to tranexamic acid. They used a cell saver, but no factor concentrate was used in any of the patient, even in the recent years. So Europe, they tend to use a lot of factor concentrate, but they actually had this program without factor concentrate, which makes it more pertinent to the US practice. So looking at the basic demographics, late 60s, male dominant, and as you can expect, mostly CABG patient, more than 50% CABG patient, or combined CABG and valve procedure. And you notice that little bit of a TAVI coming in, probably more recent years, and then just a little bit of an aortic and bento surgery. So I think they tend to select low-risk patient compared to a very high-risk bleeding patient, such as, total arch replacement. So those patients are not going to be managed at their medical center. So what they did before surgery, they focused on a pre-op antithrombotic discontinuation. So aspirin, they seed for 6 days, and then P2Y12 inhibitor, 13 days. So this might have caused relatively high incidence of pre-op MI and cardiac ischemia, almost 11% MI and 35.7% cardiac ischemia. So this may be a little bit of an issue. I think personally, I wouldn't go this long for discontinuing antiplatelet medication, especially for CABG patient. Anticoagulant discontinuation was 7 days, mostly for warfarin. So what they did was they looked at the potential mortality predicted from their baseline demographics, and they estimated about 5% mortality predicted for their population. But in the end, they were able to see that 0.6% mortality. So this study really shows that if you select the patient carefully and then manage them preoperatively well, even if you do not use factor concentrate, you are able to manage patient with blood without increasing the risk of mortality. So it's quite encouraging. I think there are lots of points that we can critique about this study, but I do think it's a very encouraging study. So another one, this is much more global population. It's not just a surgery patient, but medicine patient included. Dr. Steve Frank's study from Johns Hopkins, they looked at about 5 years worth of data from 12 to 16, and they had a 0.8% or 1,100 patient who had underwent bloodless medicine surgery program. So that's out of 138,000 patients at that time. So bloodless surgery among this 1,100 patients was 37%. And this is the list of surgical procedures they underwent. So mostly general surgery and OBGYN neurosurgery. So cardiac surgery was about 5%, only 22 patients. So in terms of cardiac surgery, it doesn't provide that much data, but I think it gives you a general view on the Jehovah's Witness patient undergoing surgery. So this is the data about bloodless surgery compared to standard of care. So if you just compare all the demographic data, pretty much, similar population, middle-aged, male with 30 to 45%, and it's, chronic metabolic disease was common, obesity common. You can see that Jehovah's Witness patient did not receive any blood, but almost 25 to 30% rate of any type of blood transfusion in a standard of care patient. Now, looking at the nadir, hemoglobin less than 5 was 1% in a bloodless surgery program versus 0.4%. So some of the patients, even under the standard care, hemoglobin can drop below 5. So in terms of the risk, yes, almost twice as high, but I think it's not far from the standard care, and which is interesting. If you look at the last hemoglobin before discharge, it's almost the same, despite the lack of blood transfusion in this population. So looking at the mortality between bloodless and standard care, actually it's 0.7% versus 1.2%. So again, statistically, there was no significance between the two groups. Of course, we pay more attention to bloodless surgery patient, more meticulous anastomosis, and then, more careful post-op care. But still, I do think that, this study really shows that, it's something achievable if you make effort to establish this type of program in your institution. So looking at the other composite outcomes, including infection and thrombosis, renal dysfunction, respiratory and ischemic event, bloodless surgery, and compared to standard care, there was no statistically significant difference. So if you look at the odds ratio, it's a little bit high, but there was no statistically different significance when you look at all the composite morbidity compared to the standard care. And in terms of infection, I do think this is a kind of interesting point, because we often think that blood transfusion will cause immunomodulation and an increase in infection. But this study showed that opposite data. Actually, avoiding blood transfusion per se did not significantly reduce infection rate after surgery. So I think the jury is still out there, but it's very difficult to show the blood transfusion effect per se on clinical outcomes. So just going back to the pre-op anemia management, of course, the low hematocrit is a key driver, when it comes to blood transfusion during and after surgery. And again, the challenge is that we are okay with larger patient. Typical patient we have in Oklahoma is, BMI 35. So that's actually easy. But when it comes to BMI 23 or even 20, I think these patients are more common in Asia and some other parts of the world. I think it gives a lot of challenge in managing those patients without blood transfusion. So erythropoietin, I think it's a really important therapy. And if you have 3 days, you can actually increase the reticulocyte. If you have 7 days, you can actually increase the red cell level equivalent to 1 unit RBC transfusion. And if you want to achieve the max effect, you need about 2 weeks. So, time is the key. If you have more time, you are able to achieve your goal much more easily. So this is just one example of EPO, iron, vitamin, and all these therapies you can do before surgery. I do not have to go into the details. This is not the standard. I think each institution have its own protocol. So what about TAVR? Increasingly we are doing non-invasive approach. And if you look at the open surgical aortic valve replacement, transfusion rate is about 50%. But if you do TAVR, yeah, it's usually 16 to 20%. So that's actually pretty good. And the Marino study from 2020 shows that the transfusion rate was about 16%. And if you transfuse, it's almost 2 units transfusion. And in those patients, hazard ratio for mortality was actually twice as high compared to non-transfused patients. So why does that happen? I think it's interesting to look at it. So what's the most predictive variables for blood transfusion in TAVR? Of course, it's a major bleeding and a major vascular complication. So those two are biggies. So if they have a complex procedural issue, there's much higher chance of giving transfusion. So even if it's a non-invasive procedure, procedurist has to pay really good attention to avoid and prevent any type of vascular complications. And again, baseline hemoglobin, lower hematocrit is a major predictor of transfusion in this patient population. So another interesting data this paper provides is a different range of NADA hemoglobin. So if you look at the data, if hemoglobin NADA was less than 7.5, transfusion group had actually worse outcome. So if you go down to 7.5 range, even if you transfuse, outcome could be pretty bad. Right? So if you have a NADA range 7.5 and 9.5, and then if you transfuse, there's not that much difference between the two groups. Now, if you have hemoglobin NADA 9.5 and higher and give transfusion to these patients, actually the outcome could be worse. So again, there's a nice range of hemoglobin that you may want to transfuse these patients to avoid any type of blood transfusion related issues or ischemia related issues. So I think there may be some NADA that we have to abide by, and maybe 7.5, once you reach there, we start to get in trouble, even if you give transfusion. So that's something we have to keep in mind. So always there's a question about causation versus association. Transfusion may be life-saving in very low hemoglobin, but if you give it in unnecessary situations, it may be associated with worse outcomes. So antithrombotic agent, this is a nice chart from European Cardiothoracic Anesthesia and Surgical Society. This actually shows very interesting diagram here because they actually mention high risk of bleeding in those who refuse blood transfusion. So if you are doing monotherapy with aspirin, they actually suggest stopping aspirin before surgery. Now, many of you may argue against it, and I personally think it's reasonable in high-risk case to keep the aspirin going. But they generally say if it's a DAPT patient, very high risk for thrombosis, you can continue aspirin until the day of surgery. Again, you have to really look at the risk of the patient, especially in Jehovah's Witness patient, and decide what to do. Sometimes you can use cangrelor, really low, short-acting P2Y12 inhibitor so that you can stop the drug right before surgery. So there are many different ways to manage antithrombotic therapy in 21st century compared to when I was doing a fellowship in the late 90s. So pre-op, warfarin and direct oral anticoagulants. Of course, for DOAC, we can stop, 2 or 3 days before surgery. And then there's even a potential for reversal agents. So that, that could help you managing severe bleeding situations. I'm not recommending andexanet before cardiopulmonary bypass, and we can discuss that in QA session. But I think there are ways to manage oral anticoagulants. So this is a very nice recommendation that was associated with the Zimarino's paper. This is from editorial, but it shows all the things we have to do to avoid blood transfusion. Of course, we have to think about restrictive threshold and then avoid hemodilution. Perfusionists can help a lot in this area. Antithrombotic therapy, stopping, and then treating anemia. These should be done by primary service. And again, procedurist or surgeon has to be very judicious about accessing cannulations and incisions during the procedure. So those are the 5 important elements to support bloodless surgery in non-invasive and invasive surgery as well. So in a Jehovah's Witness patient, we have to think about 2 main protocols, cell salvage and ANH. So when you look at the cell salvage, red cells are really well preserved by cell salvage. But if you look at the platelet contents and plasma coagulation factors and then cryoprecipitate contents in a cell salvage unit, it's not really there. It's not really therapeutic. So the more you do, you may lose these extra, coagulation elements. Now, ANH, if you do that, you can actually preserve all of those elements. So there is some advantage in using ANH. And when it comes to other alternatives, now bovine hemoglobin used to be available in many centers, but now it's very difficult to obtain. So there's really nothing that we can use to replace red cells. Platelet, there's nothing at this point to replace. So that narrows our options to PCC, antithrombin, albumin, and some of the concentrate currently available on the market, such as fibrinogen concentrate and DDAVP. So just to show you what happens after you process the unit in the cell saver, you have a baseline fibrinogen in the shed blood, about probably 90 milligram per deciliter, that goes down to almost 20 or 30. And then that also happens to the prothrombin and factor 13. So you lose most of the factors as you process. And if you process 5 or 10 units of cell saver, you basically only have red cells in the patient. Now, another interesting development recently is the solver, and this is something you might have seen during the COVID pandemic. And I think in that situation, you are using it to remove cytokines from the COVID patient, but the same approach could be used. So this actually picture showed this beads in the zoom up, and you can see the drug, this the little balls, they are actually adsorbed, trapped into this beads, and that's how you can potentially remove Tycag or rivaroxaban or apixaban if the drug levels are really high. So this system provides really large surface area, 40,000 square feet, and you can take out a lot of cytokines and drugs, and you can put it in parallel to the cardiopulmonary bypass circuit, such as this one. So this is a pump, and you can see the blood going through and come back to the reservoir. So by doing this in conjunction with just running cardiopulmonary bypass, if you have a long pump time, you can potentially lower anticoagulant levels. So if you have an emergency case, you have a lot of Tycag in the patient, you can potentially help reduce that drug level. So one caveat is that the higher the concentration of the drug, the better you can remove it. So if the drug level is actually low, it actually takes much longer to remove it. So this is one caveat. If you have a very good surgeon and pump time is 45 minutes, it may be really difficult to remove the drugs, especially when it's a lower concentration. And one other caveat is that the platelet tends to go down about 15% if you keep running this system for about 2 hours. So that's another potential consideration, especially in Jehovah's Witness patient. So ANH, my favorite subject. So this is the autologous whole blood collection. And once anesthesiologist place this MAC catheter and connect this situated tube to this port, you can actually drain the blood, 25 to 30 cc per minute. So it's a slow enough drainage. It does not usually cause severe hemodynamic derangement unless you take out too much, like 2 liters of blood from the patient. So generally speaking, I and my colleagues can take about 1 liter if BMI is about 30. Now, smaller patient, probably 600 cc's, but it's really feasible in any practice in the US. So what happens in non-Jehovah's Witness patient? We often give red cell during cardiopulmonary bypass, and after we come off bypass and give protamine, we give platelet because patient's bleeding, and you see the oozing. Surgeon complains about oozing in the field, and we end up giving platelets. And that's how I decided to do ANH by having ANH unit available. Before we move on to the platelet or red cell, I can always tell surgeon we have an ANH blood, you're going to give it back. So we can actually buy time. That's how I started, just to break this bad habit. I started this around 2016, and then we gradually expanded the program. So everybody started doing it, and we were able to reduce the transfusion rate, when I was in University of Maryland. So I think it's a small step, but having something at the end really helps surgeon feel better. And then, you can actually change the culture. So it's really interesting that even a small step, and if you put it in, into the program and do it every day, everybody gets really good at it. And in perfusionists, they get used to it. And I'll talk about it in the next slide, but you can definitely help achieve much better patient management, blood management program. So this is an issue. So I call it tug of war. So if I take too much, perfusionists cannot do a good wrap. So ANH, by definition, we dilute, right? The perfusionists try not to dilute, and they do wrap. And so this is a really dichotomy, and sometimes it's difficult to balance, especially in the beginning. But if you think about it, platelet and factors stay out of the socket. But if you do wrap, all the factors are still in the patient and potentially damaged or lost over time, the cardiopulmonary bypass. So let's think, we are actually aiming the same thing. Our goal is the same, not to come back for rebleed. And, we want to sleep all night after the case. So let's be nice to each other and figure this out before you start the case. I think that will really create a good culture. Okay, so what happens to the patient? So this is the clinical effects on the hematocrit when you do ANH. Yes, NADA hematocrit tends to be lower, but once you get to the ICU, actually hematocrit reverses. ANH group has higher hematocrit, and that is maintained until the time of discharge. So this is a really good effect because you can really reduce the post-op transfusion. And I can show you this. So if you don't do ANH, this is 100 patients, just a retrospective review, but you tend to give couple units after surgery. Even if you avoid any transfusion interrupt, you give a couple units after surgery. But if you do ANH, since bleeding goes down, you give much less after surgery. And I think you have much less variation in overall unit use. If you look at the control group, you have much higher variability from patient to patient. So reducing the variability in clinical practice or transfusion practice, this is a very important point. So what's in the ANH blood? So think about, we take out 1 liter from the patient and the hematocrit is about 40% and baseline fibrinogen at 3.8 liters. You can actually collect 2.3 grams of fibrinogen in that bag. And, we actually measured all the factors in the bag, and you actually take almost a unit of platelet bag and then 2.5 vials of fibrinogen concentrate. And it's a little bit over 1 box of PCC and then von Willebrand factor 8 units. So you actually collect a lot of valuable factor concentrate from each patient. And this is very interesting because our patient population, patient in 60s and 70s, they have a lot of inflammation, including myself. I'm in 50s, so I do have lots more inflammation compared to those in 20s. So you see the fibrinogen level keeps going up. Female actually have much higher fibrinogen level. This is an Italian study, but CRP tends to go up as we age, and the fibrinogen tends to go up. So if you look at the trauma patient, they come in with really low fibrinogen, but our patient have a very good fibrinogen. So you can take advantage of that. So that's how ANH works in my mind. So that way we don't have to spend so much money in fibrinogen or PCC concentrate after cardiopulmonary bypass. But body mass index, of course, is a problem because I have taught this technique to my Asian colleagues, and they tell me that their BMI is 23. So it's really hard to do because red cell mass is almost 1 unit red cell less, right? So once you dilute on bypass, hemoglobin tends to go below 6, and you end up giving red cells. So again, each practice has to think about what's the total blood transfusion. If they're giving lots of platelets after surgery, maybe it's one consideration. You can use just red cell on bypass, but you can keep the autologous unit until the end. So I think this is a site, institution specific decision making, and sometimes patient level decision making. So there's no standardized amount that we should take from each patient. Okay, so I'll just go to the case description, and this is a very interesting case because this patient came as a 43-year-old and a 58-kilo patient. This is the redo surgery, and I showed you the first slide with a cardiopulmonary bypass long time ago. She was operated at that institution some years ago by Dr. Cooley. So this is a redo. So I have to keep this patient alive, but you can see that she has a relatively low body weight, and hemoglobin is okay. She was getting a lots of EPO, but hemoglobin was not 15 or 16. So overall, she has a relatively low BMI, low blood volume. And if you calculate her transfusion risk based on the trust score, 80 to 100% chance of getting red cell transfusion. So this is a really challenging case, especially if, it's a redo. And she's a Jehovah's Witness. So what do we do? So again, I discussed that it's really difficult to do high volume ANH, autologous blood collection, and I expect the hemoglobin will go below 6 grams per deciliter. So fortunately, at that time, I was able to get HBOC, bovine hemoglobin glutamate from the company, and I was able to contact FDA, get the temporary FDA approval for this specific patient. And this glutamate has hemoglobin of about 12 to 14, so similar to the blood component unit. And a half-life is about 1 day. So this is a reasonable option. And I was intending to use this agent to support oxygenation during cardiopulmonary bypass. And the side effect, of course, is the hypertension, methylhemoglobinemia, and potential for stroke and MI. So this is what happened. We took off about 1 liter from this patient. Hemoglobin was actually pretty good because we did not give too much fluid after taking off the blood. We gave a little bit of blood, 500 cc's or so. But after we went on bypass, of course, hemodilution occurs. And we ended up giving 2 units of HBOC to just push up the oxygenation. So this is a cerebral oximetry. So you can see how it changes oxygen carrying capacity. So by giving HBOC, you can see the boost of oxygen saturation. But over time, again, it started to go down. So we ended up giving another HBOC, bovine hemoglobin, when the hemoglobin was 6.7. And then we boosted up oxygenation again. And that's the time when we came off, and then we were able to give autologous unit back. And then at the end, with the factor concentrate usage, we were able to maintain hemoglobin of 9.4 after surgery. So this is what happened, end of the bypass right here in the middle. And then as soon as we came off, we actually gave lots of product around the same time. And I will explain how we did it, but basically the multifactorial therapy at the same time. So in general practice, we don't think this way. We don't really give everything at the same time. We tend to give one thing at a time, and we see the response and then follow up. But that practice tends to cause more bleeding because, you know, if you don't have full information, say you get the platelet back and give platelets, and then after that, you get the information about fibrinogen, you order cryo, and there's always a delay. So having factor concentrate and immediately replace what's missing is actually a very effective way to reduce bleeding after surgery. And you can see we only gave 150 of protamine based on her HepCon results, and we didn't have to give any extra protamine, but she had a reasonable hemostasis. So after 30 minutes, we actually started to give nicardipine, just a little bit of epi support, and with prostacyclin, we were able to keep her pulmonary artery pressure low, and then she actually went to the ICU in a stable condition. So what we used here was a thromboelastometry. Some of you know that TAG and ROTEM. This is a ROTEM system, and we used the ROTEM during the cardiopulmonary bypass, and we saw a prolongation of clotting time. So we already decided we're going to support her with a little bit of PCC and also a little bit of fibrinogen because she's small and she continues to get diluted. So as soon as we came off, we actually gave a small dose of PCC, 10 units per kilo, and then fibrinogen adult dose. And then we were able to get the ROTEM parameters optimized before we bring the patient to the ICU. So later we got the results back. PT was 16.9, INR 1.3, fibrinogen was 220. So we were not too far off from what we thought on the ROTEM system. So having a point of care coagulation definitely help you understand the coagulopathy, and you can do patient-specific targeted replacement. So post-op course are pretty good, nicardipine drip to just manage the blood pressure, and otherwise, you know, no methylene blue was needed, so she was okay. And post-op bleeding was only 260 cc's, and then she was extubated next day and then went home on day 6. So very good outcome. So limitation with HBOC, it's not really available anymore. They're doing a big study in South Africa. So most of the units are shifted to South African area. So we don't have much in the US. Maybe Dr. Steve Frank might have some in Johns Hopkins, but I do not have it. I don't have access at this point. So anecdotal data, most of the case reports are very not really evidence-based data. So we still have very limited safety information. So one last, just switching gear a little bit and talk about ECMO. So this is a very interesting long-term ECMO case in Jehovah's Witness patient. And of course, he refuses transfusion. So this patient came in and severe hypoxia, needs ECMO, initially VV ECMO, but later cardiac failure. So need to switch to VA ECMO. So hemoglobin went down. We can't give any red cells, but also the platelet count went down, and there was oozing in the cannula. So they have to manage something. In an ECMO patient, acquired von Willebrand disease is common. You know, multimers are consumed, so low platelet count and then low multimers of the von Willebrand factor cause much more oozing and bleeding in the cannulation site and other, you know, wounds. So you have to do something about it. So of course, we cannot get any synthetic platelet, right? So what do? So they actually did a very interesting thing. They use romiflostim. This is a thrombopoietin. So they gave thrombopoietin to maintain higher platelet count. And then patient was weaned off after 44 days and it actually went home. So it's a very interesting data. There are lots of thrombopoietin studies in chronic liver patients. So you might see it in liver transplant. But if the baseline platelet count is about 37,000, after you give 7 days of thrombopoietin, such as loose thrombopag, you can actually increase the platelet count, over 12 days, and then you can actually reduce the rate of platelet transfusion. So in this case, down to 31% versus almost 75% in a placebo control group. So there are multiple thrombopoietin available. So in a dire situation, this is something you can ask a hematologist to consult on your patient, especially if it's a long-term ECMO, you can ask for help. These are off-label use because these drugs are indicated for ITP and chronic liver disease. Okay. So this is just one example in a cirrhotic patient. If you give this drug, after 5 days, you can start to see the platelet count increase, and then you can see the peak of 80,000. I think this is a really nice range that you want to maintain in a high bleeding risk patient. So this is something you can consider. You can almost double the platelet count by this type of agent. Okay, just to summarize my talks today, I think supporting blood surgery, this is a multidisciplinary effort, pre-op management, EPO, TPO, and iron and vitamins, and an intra-op, you guys, perfusionists, can do a lot to support this, RAP, cell salvage, and helping us do ANH. And of course, antifibrinolytic and topical hemostatics, we have to routinely implement it. But with this type of collaboration and with some blood alternatives, it's a limited, amount of products available to us at this point. But I do think we can achieve fairly safe bloodless surgery in most of our Jehovah's Witness patients. So what's coming in the future? So there are several companies other than Hemopure that is trying to develop alternative to the red cells. So this one company, Colocyte, based in Baltimore, they're trying to make one such product. And also there are multiple companies trying to develop nanoparticle-based thrombocyte platelets. So this can be given to Jehovah's Witness patient because these are synthetic products. And if you have a surface, GP2B3A or GP1B receptor, potentially that can help support vascular hemostasis in high-risk patients. So that's pretty much wraps up my talk. In summary, PBM, it's a premise of bloodless surgery, and bloodless arrangement really takes time. So, 2 weeks to get optimized effect for EPO and TPO. And then there's always a learning curve for CPB techniques, ANH, TEG, and ROTEM, and combination of these techniques. So I think we have to really develop a team to do this. And lastly, bloodless complex surgery, cardiac surgery, it's feasible, but definitely there's a risk of mortality. So it has to be chosen by the patient. So patient-centered approach, that's most important. And in combination of products, it's available to cover most blood functions. And then again, I have to stress, multidisciplinary effort is the key to the success. Thank you for your attention.
Thank you very much, Dr. Tanaka. Really a great presentation. And I'm sure a lot of people in our audience today have had these cases to do, and they present a very complex situation. All patients are a multivariable formula, and this just adds an additional complexity. I have the first question. I kind of want to combine it with one of the things from the question and answer board. So kind of a two-part. First, I really looked at what you presented as far as ANH and really utilizing it as a technique and a tool really aid in treating the patient. So the two-part question is, how do you keep that connected to the patient in simple terms, if you can? Also taking into effect that blood has to be agitated, as we know, throughout the procedure. And then the second part is some of the Jehovah Witnesses are refusing ANH. And maybe the patient's not educated, maybe the patient is. We know that sometimes they all come with different requirements or different little twists. How do we make this so that a Jehovah Witness is easily accepts this?
Right. So I think first question is about ANH bag. How do we collect it? How do we keep it connected to the patient? So I think this is a very interesting question, and that also applies to cell saver. You know, we think it's connected if it's a contiguous circuit, but you know, I think it's a almost philosophical question. But in my case, I keep it connected and I keep that stopcock partially closed so it doesn't really keep going back to the patient, because if you just keep it open, you know, there's some IV going and I think the blood can go back to the patient. So that the small port of the MAC catheter, you know, theoretically, you don't have to give any fluid as long as just connect to the patient and don't do anything about it. Just a partially closed line, it's still connected to the patient, and that's what I think is acceptable in this situation, because I do not want any fluid going back into the into the patient. So in terms of agitation, that is still undetermined. So in my situation, I add a little bit of heparin to the bag. So it's 1.5 cc, to the bag. So actually my blood is heparinized in conjunction with citrate. So we have a double anticoagulation inside the bag, and I've never had any reheparinization issue because we tend to give overdose of protamine when we give the blood back. So with that, I don't really have to agitate that much. I think it's okay to agitate. You can actually put the agitator on the floor and just continuously agitate. That's feasible. But even if you don't agitate, when I add a heparin, added to the citrate, I just don't have that much issue in, clotting or some type of agglutination inside the bag.
And as far as convincing the patient to possibly refuse ANH?
Yeah, so that's a really good question. And I think here you can ask the Jehovah's Witness liaison. There's always somebody in that city or area who can consult the patient. And in my case, I actually talked to the liaison first, and I explained every single one techniques that I was going to use. And then liaison was able to talk to the patient, and she agreed to all the protocols. And again, there's always patient-centered approach. So if somebody says, I do not want to ANH, I guess we just can't do ANH, but we have to explain the potential consequences.
And thank you, Dr. Tanaka, thank you so much. I'm going to ask you, if you don't mind, there's so many questions, if you could minimize your responses just so that we can get through some of these. We're almost running out of time, and a lot of it is on ANH. I want to thank everybody who's using the Q&A form. There's great questions here. Helen Scarrett is asking, how much heparin do you put in each bag?
So I put about 1.5 cc, so 1,500 unit. Some of my colleagues do 2 cc, and I don't really have any heparinization issue. Okay.
ANH has not received very positive recommendations from the most recent STS blood management guidelines, but do you feel that perhaps with a specialized patient population as Jehovah Witnesses, that we should relook at it and apply some of those randomized trials to Jehovah Witnesses for ANH?
Yeah, I do think that, especially patient who refuses the blood and then say having high fibrinogen baseline, it definitely helps. This is a volume dependent effect. So if you only take 400 cc, of course, it does not work. So all ANH are not equal. I think you really have to do more aggressive 600, 800 cc ANH than 300, 400 cc ANH.
Jeff?
Yeah, just to comment a little bit about your HBOC, and I know it's no longer available, I guess. There was a question on the forum that said essentially the HBOC caused a lot of complications. So what was your experience with that?
Right. So I think in the past, all the studies were using HBOC more after cardiopulmonary bypass, not actively during cardiopulmonary bypass. So if you give it through IV, of course, it has to go through the lung. So, I think I have this bias. If you give it through IV, you have to go through the lung. But if I give it on bypass, I can go through you guys, oxygenate and give it back. So there might be some difference. It's hard to do a study, give all the blood products, except platelets on bypass type of study. I think it's difficult, but I think avoiding the lung may make a huge difference. So I think as long as you can use it as a carrier during cardiopulmonary bypass and then give it as oxygenated state, it might actually work well. Has to be done, has to do a study.
Dr. Tanaka, there are a few questions on that regards to the pediatric population. If you are doing a patient tomorrow who comes in at 15, say that's 15 years old for an AV canal, a redo AV canal, or a congenital, what do you tell the family, and what is the legal requirements in the state of Oklahoma for having a parent refuse blood transfusion?
So we are able to get a court order to administer blood if we think it's medically indicated. I think it's good to discuss with the parents, what we can do as a bloodless management approach, and if that doesn't work, we can still divulge what are the options. And if I think saving the child's life, I think it's a prime importance. And I do think, getting a court order, and we can do it in a timely manner, I think it's really, important. So I would still explain to the parents that, that is a process we will, consider if this situation happens. But, since it's a 15-year-old, and if hematocrit is pretty good, I think, odds are pretty good in terms of avoiding any transfusion. So I think you just have to have a good communication with the parents.
I think here in the state of Pennsylvania, the laws, anybody can correct me if I'm wrong, or even talk about your own states, that once you're 19 years or younger than 19 years of age, parents cannot refuse to transfuse the patients if it's a medical necessity, but I'm sure that varies. We have a lot of questions and there's a lot of comments. I really hope everybody has a chance to look through the Q&A. My computer died, so when I
I'm happy to offline just answer some of the questions. If you can just send me a screenshot or just retype some of the questions.
Absolutely, that's great. And Maggie, if you can advance the slides, I'll quickly talk about this next slide, and then we'll see Dr. Tanaka's his email address. He's a wonderful communicator, has been all the times that I've been communicating with him. Before I thank Dr. Tanaka, I just want to state that our next presentation is given by Mark Caruso, and this is an outstanding presentation. If you have not heard this in the past about what went on during Gibbon's first successful use of CPB, and it's actually questionable whether it was successful or not in regards to at least the perfusion run. But Dr. Tanaka, I want to thank you. You've done a wonderful job. I think one of the most important take-home messages was in your last slide, where you showed the multifactorial aspect that goes into blood management. Tonight, we've been talking about Jehovah Witnesses, but so much of what you've stated, and you've presented this through a lot of your citations, are applying to patients in general. We didn't talk about ultrafiltration. Clearly, there's a need for that in this particular patient population and in others as well, and that's something that we need to consider
Yes.
as an important aspect.
Yeah, you guys know it all, so I wasn't even trying to.
Exactly. But listen, Dr. Tanaka, thank you so much. You've done a phenomenal job today. And as always, there's a lot more questions that were generated, and we could see in the Q&A, it's totally lit up. So we actually will invite you back for a follow-up presentation in the future, because I think the blood management discussion can go on so many levels, and perfusionists are intimately involved, as anesthesiologists are. So I'd like to conclude by thanking Jeff, as always, a wonderful co-moderator, and just great to have on board Maggie, who is the woman behind the scenes who does all the logistical, and of course, all of our attendees tonight. I really want to thank you all for spending the time with this with us, and to listen to Dr. Tanaka and all the words of wisdom that he was able to present. So thank you all, and we wish everybody a wonderful evening.
Thank you, Jeff. Thank you, everyone.
Thank you, everybody.